Thank you, and thank you all for the invitation to present today. These are my disclosures. Targeted therapy in non-small cell lung cancer has advanced rapidly, particularly in the metastatic setting. We've seen not only the development of multiple new inhibitors for old targets like EGFR, ALK, and ROS1, but multiple new targets identified: MET, HER2, BRAF, the list goes on and on. And for each of these, there now exists effective and tolerable kinase inhibitors, frequently multiple lines of treatment, in fact. However, for each of these agents, the duration of effect is limited. Acquired resistance to targeted therapy is inevitable in any patient that is treated with a targeted therapy. And if we take EGFR mutant non-small cell lung cancer as one example, we see that in patients that are treated with initial kinase inhibitors, about 50 to 70% of them will eventually develop a specific type of resistance mutation, the EGFR T790M. There are other types of resistance mutations that can arise, but increasingly we now have novel inhibitors that can actually address these resistance mutations. In the case of EGFR T790M, we have the new kinase inhibitor osimertinib. When we look at ALK mutant non-small cell lung cancer, the situation is slightly different, but fundamentally similar, in which we have multiple second and third generation inhibitors, but each of these work only for a subset of resistance mutations. And as you can see from the chart on the right, for each of these agents that we have available in the second or third line, they will only hit very specific resistance mutations. And thus, increasingly, we need to actually know why a given patient is progressing on their initial treatment. Therapeutic decisions thus hinge upon the detection of these genomic alterations, both the initial sensitizing mutations, which we would traditionally pick up on a patient's initial biopsy, as well as these acquired resistance mutations that historically could only be detected on repeat biopsies at the time of resistance. Plasma genotyping technology, in contrast to traditional tissue genotyping technology, offers an alternate avenue to potentially detect these mutations. Plasma genotyping takes advantage of cell-free DNA, the fraction of DNA outside of cells in the plasma, and this consists in oncology patients of a mix of both genomic DNA from normal cells as well as tumor DNA. And plasma genotyping takes this cell-free DNA and performs the genotyping that we would normally perform on tissue. And it can potentially avoid some of the limitations that are associated with tissue genotyping. It has potential utility for detecting sensitizing mutations, resistance mutations, and given that you can perform a blood sample much more easily than a biopsy, it also allows us to monitor the actual genetic evolution of tumors and potentially monitor their response to therapy. In addition to those potential uses, there are some inherent advantages of plasma genotyping in that it is obviously non-invasive. You can potentially get the results much faster than having to get a repeat biopsy and perform tissue genotyping as well as tissue processing. And beyond that, it's potentially less costly, particularly when you factor in the cost of managing complications of repeat biopsies, such as pneumothoraces. And as I mentioned, it can potentially provide a real-time flow of information on the genetics of a patient's tumor. Multiple platforms exist at present for plasma genotyping, and I won't go into each one, but a lot of them are technologies that were developed for tissue genotyping that have now been repurposed for plasma genotyping. And so they range from a traditional PCR-based platform like COBAS, which is now FDA approved for both tissue and plasma genotyping, to more modern platforms like ddPCR and beaming, which are highly sensitive quantitative panels, to NGS panels, which are kind of broader panels that can pick up a wider range of alterations. And a lot of the commercial assays that are available in the United States are actually NGS platforms. So the Garden 360 that you're probably familiar with, the Foundation ACT panel, Illumina, these are all NGS-based panels, and there are many others that you will probably see out there commercially. However, when we think about actually using this technology to predict someone's genotype either at diagnosis or at acquired resistance, it's important to take a step back and think about the biology that we're actually contending with this technology. So when we think about cfDNA, patients fall into one of two biologic scenarios. They either have a tumor that's shedding a lot of cfDNA into the peripheral circulation, or they have a tumor that is not shedding a lot of cfDNA into the peripheral circulation. And in patients that have shedding tumors, plasma genotyping really works the same as tissue genotyping. If you pick something up, you can trust that it's there. If you can't detect something, you can trust that it's not there. In a non-shedding patient, if you do not pick up a mutation, you do not know which situation you are in, meaning your test could be a false negative or it could be a true negative. The challenge with plasma genotyping, and I'm going to go through some actual studies in a moment, is that we can't determine a priori which patient we are dealing with, whether they have a shedding tumor or a non-shedding tumor. And I'm going to talk a bit about how to interpret the results of this technology, keeping that biology in mind. So, comes to the very simple question, how accurate is this new technology, in particular compared to tissue genotyping? And when I was at the Farber, we actually tried to answer this question with a prospective study. So we recruited 180 patients with either newly diagnosed metastatic non-small cell lung cancer or patients with acquired resistance to an EGFR inhibitor. And we compared at multiple time points the results of plasma genotyping, looking at a limited panel of EGFR and KRAS, to tissue genotyping based on paired tissue biopsies. What we found was that this technology is highly specific for the detection of EGFR and KRAS mutations, meaning that you really have 100% specificity for EGFR sensitizing mutations and KRAS mutations, and thus a 100% positive predictive value. So with a properly designed plasma genotyping assay, when you get a positive result for a targetable genomic alteration, you can trust that and you can treat on the basis of that, and you don't need to confirm that on a tissue biopsy. Sensitivity is a different matter, and this goes back to what I was talking about earlier about not being able to tell if a patient's tumor is shedding or not a priori. And thus, the sensitivity of this assay is in the 70 to 80% range, meaning that if you get a negative result with this test, most of the time it's a true negative, but sometimes it is a false negative. And thus, in these patients, you really need to reflex to tissue to confirm a negative result. You've probably already noted that for EGFR T790M, that acquired resistance mutation, the specificity seems lower as well as a positive predictive value. And when we were running this trial, we were using tissue genotyping as our reference standard. So that's what these numbers are in comparison to. And what we found with these patients where we were getting what we thought were false positives was that when we went back and biopsied them again, we would then get a positive T790M. And what we quickly realized is that we were picking up something that was biologically very important. And that was that in acquired resistance, as opposed to an initial driver mutation, you see heterogeneity between metastatic sites. And thus, in a given patient, you can biopsy two metastatic sites. One might have an acquired resistance mutation, it's usually the growing site, and one might not have it. Plasma kind of gives you an average across those sites, and thus for acquired resistance, plasma has an inherent advantage for kind of picking up what is going on average across a patient's metastatic sites. We also looked at whether there were characteristics of patients that predicted for increased assay sensitivity. And what we found was that as you had a greater disease burden or an increasing number of metastatic sites, the sensitivity of the assay increased. And when you had a patient that had widely metastatic disease, the sensitivity reached 100%. So in patients that have multiple metastases, especially liver metastases, the assay is far more sensitive as opposed to a patient that might just have primary and maybe one or two radiated bone metastases, for example. Heather Wakely at Stanford has taken this a step further and looked at combining plasma genotyping with urine genotyping with tissue genotyping. And what she found looking at the TIGER-X study was that in patients that had all three types of genotyping done, you can actually get at 100% sensitivity. Each method picks up patients that are potentially missed by the other method. And another important finding from this was that when you combine plasma with tissue, you get a pretty high sensitivity without necessarily needing to add in the urine. And thus, I would view these genotyping methods as being complementary, particularly in the acquired resistance setting. So when we think about applying plasma genotyping to newly diagnosed patients, rapid detection of mutations is possible in newly diagnosed patients using this technology. A positive result in a newly diagnosed patient is immediately actionable. I think the challenge is that often a patient has already had a diagnostic biopsy, and thus genotyping based on that diagnostic biopsy is probably already in the pipeline or might already be available. And I think this limits the utility of plasma genotyping in newly diagnosed patients. However, there are certain instances in which I think this technology is still useful in the newly diagnosed patient. And I think in patients where they have insufficient tissue on their initial biopsy for genotyping, it can be helpful in terms of speeding up genotyping without having to repeat a biopsy on a patient. I think in patients who are difficult biopsies, where you're worried about actually going back to try to get more tissue in the initial diagnostic setting, this technology can be helpful. And in patients that have rapidly progressive disease, I think this technology can be useful. And there were a few instances at the Farber where we would have young patients, never smokers, they'd present with rapidly progressive metastatic disease. And before we had time to perform genotyping on their biopsy, they would be intubated in the ICU. And using this technology, we were actually able to identify a handful of them that had EGFR mutations. And a subset of those we were able to give erlotinib to through an NG and actually have them come off the ventilator, which is quite extraordinary. And I think that is a very useful application of this technology, albeit in a very limited subset of patients. Where I think this technology is more useful is at the time of acquired resistance or radiographic progression. At that point, this technology is highly specific and highly actionable, and it can detect acquired resistance mutations that you might actually miss on a repeat biopsy due to heterogeneity of acquired resistance. Plasma NGS in particular, I think, can be useful in this context because it can not only detect EGFR resistance mutations, but it can detect a wide range of other resistance mutations and allows for a broader panel than you might see with ddPCR. But taking this a step further, can you use this technology not only to pick up a mechanism of resistance, but actually to predict which patients are going to fail and actually monitor for the moment at which acquired resistance emerges? So flipping my study on its head, could we have started checking some of these patients sooner and picked up that they were going to become a T790M acquired resistance before they actually progressed on their CT scan? And so a few studies have looked at trying to answer this question. And what is interesting about this method is that plasma genotyping, as I mentioned, is potentially more sensitive than radiographic methods and has the potential to detect both emerging resistance and mechanism of resistance early on. And so what we and a few other groups have looked at is how we can use plasma kinetics, the change in quantitative plasma cfDNA over time, to actually monitor for response and progression. So one of the first people to look at this was Tony Mock in Hong Kong, and he actually looked back retrospectively on the FASTAC, it was either the FASTAC study or one of the other chemotherapy plus EGFR inhibitor studies. And what he found was that in patients that had complete clearance of EGFR cfDNA in their plasma before their first scan, they did much, much better than patients who still had residual cfDNA at that time. In our study, we collected serial plasma on patients as well, and we compared that to their initial restaging scan. And what we found was that similarly, patients who had complete clearance of their plasma circulating tumor DNA had an objective response rate of 65%, irrespective of what treatment you were giving them. And almost none of those patients actually came off treatment at the first or second scan, even if they did not have a partial or complete response by the first scan. In contrast, patients who still had residual mutant cfDNA in their blood at the time, at either 2 weeks or 6 weeks before their first scan, only 19% of those went on to have a response, and the majority of those patients came off of whatever treatment they were on by the time of the first or second scan. You can also use this technology to actually pick up the mechanism of resistance early on, and a group in East Asia has been looking at this, and they found that you can actually see sometimes several months in advance the emergence of T790M long before you actually see progression on the CT imaging. In addition, as we've discussed, plasma genotyping can detect poor initial response to treatment and can also predict for progression. As I mentioned, lack of clearance of EGFR cfDNA is a poor prognostic indicator. Plasma kinetics, as we've looked at, mirror radiographic response and progression closely, and the plasma kinetics, as you monitor them, can potentially detect early progression in patients in advance of any evidence of radiographic progression. Another interesting application of this technology is actually monitoring how a tumor evolves in response to therapy. And this was an interesting study published by the folks at Guardant in collaboration with Trevor DeBona's group at UCSF. And what they demonstrated was that using plasma, you can actually monitor for the emergence of co-mutations at different metastatic sites in a given patient. And they actually found that very specific mutation or co-mutations with EGFR predicted for poor response to EGFR kinase inhibitors. So these specific co-mutations, if they were present at initial diagnosis, kind of predicted for those patients who are going to do really bad on a kinase inhibitor, especially cell cycle and MAP kinase pathway alterations. Similar principles applied for patients that were treated with T790M specific inhibitors at the time of acquired resistance. And they also hinted that the frequency of T790M across metastatic sites seemed to predict for better response to targeted therapy in the acquired resistance setting. Now, this is a very important slide, I think, particularly for surgeons. And this was a fascinating study that came out of Stanford from Max Dean's group. And what Max looked at was actually trying to use this technology not to detect targetable alterations, but actually to detect minimal residual disease after surgery. And Max uses a broader panel that he's designed called CAPSEQ that is designed to pick up any possible bit of circulating tumor DNA in the periphery. And so he applied this technology to a cohort of about 60 patients that had stage 1 to 3 disease that had undergone resection. And in these patients who had blood drawn within 3 months of having their resection, he subdivided patients based on whether they either had detectable tumor DNA in their blood at that time or did not. And what you can see is in patients who had minimal residual disease at that time using this technology, their progression-free survival and disease-specific survival was abysmal. By 2 years, the majority of these patients have had a recurrence or have had a mortality event. In patients, in contrast, that did not have any detectable minimal residual disease based on this technology, their their progression-free survival at 3 years is almost 100%. The utility of this technology to subdivide these patients into high and low risk categories is considerable. This goes through a lot of what I've just discussed. So highly sensitive panel, extreme high sensitivity for detecting minimal residual disease. That's how the panel was designed. And the utility of this technology really is to identify patients who may be candidates for additional adjuvant therapy or more modern adjuvant therapy, in particular adjuvant immunotherapy, after they've had definitive treatment of one type or another. You can also use plasma genotyping to help with immunotherapy. And in this study that was reported by David Gandera at UC Davis, he actually used the Foundation ACT panel as a surrogate measure of tumor mutational burden. And as you might know, the more mutated a tumor is, the more likely it is to respond to immunotherapy. And he actually found in this study of atezolizumab in metastatic patients that patients who had high tumor mutational burden detected from plasma did much better with immunotherapy as opposed to those that didn't. So as you can see, this is an increasingly flexible technology, and we can potentially use it as a surrogate measure of tumor mutational burden that may predict response to immunotherapy. And I think you can also tie in detection of specific mutations that might predict response to immunotherapy as well. So these are things like MSI high status or POL E or D mutations that, although they're specific mutations, they tend to spin off into a higher mutational burden as a result of their interference with DNA repair. Going beyond this, you can also use this technology, as we've discussed, for real-time monitoring of tumor status. And I've discussed using this technology as a quantitative measure of tumor burden, but also as a means of detecting what is going on genetically in a tumor over time. There's potential for this technology to allow us to modify treatment in advance of actual radiographic progression. And this technology has also allowed us to identify more rapidly newer resistance mutations that we did not know about. As you can imagine, doing studies on plasma to pick up why someone has become resistant to a new drug is much easier rather than the old approach of performing large-scale rebiopsy studies incorporated into drug development to try to figure out what the next wave of resistance mutations will look like to a new drug. As I've discussed, there's potential role for this type of technology in identifying high-risk stage 1 to 3 patients for new clinical trials and new adjuvant therapy. And there's also a potential role for this technology in selecting patients for immunotherapy. In terms of limitations and next steps for this technology, poor plasma response and detection of resistance mutations in plasma, as I've discussed, predicts for disease progression, but it's unclear at present if intervening early will actually improve the outcomes of these patients. Meaning, if I pick up a T790M mutation 3 months in advance of radiographic progression, is a patient really better off with me switching treatment at that point as opposed to waiting until they clearly progress on their scan? Meaning, am I just burning through treatment options as opposed to getting the most out of each individual treatment option? I think proper studies going forward really are needed to determine if plasma-directed interventions can improve patient survival in specific scenarios, namely early treatment switching in a poor plasma responder, early treatment switching when you detect the first resistance mutation, potential use of this technology to study the benefit of additional adjuvant therapy in different subgroups. And I think the Pacific study is a good example of this, where if we could look at patients who got adjuvant immunotherapy after chemo-RT, could we actually detect those who were more likely to benefit from this treatment using minimal residual disease type technology, and potentially using plasma genotyping to select patients for immunotherapy. There are also novel plasma-based technologies that are emerging that I don't have time to talk about, like plasma RNA-based technology that I think will be increasingly interesting as well. And thus, to conclude, this is a great technology to monitor for disease response and progression in non-small cell lung cancer. It can potentially pick out early emergence of resistance mutations and co-mutations that can help to guide therapy. And this platform overall is, although very specific, consideration of sensitivity really is key when you're using it to guide therapy. And I, again, would emphasize that early intervention based on plasma testing alone, without a patient having radiographic progression, although interesting, should remain investigational at this time. And I'd like to acknowledge all my collaborators at Princess Margaret, as well as my former institution, Columbia, and the Farber, as well as NYU, as well as the support for a lot of this research from Conquer Cancer, ASCO, and the IASLC, as well as the CIHR and DoD. Thank you.